First up is Pat Teske. She is the Implementation Officer for Cynosure Health and is currently leading the Avoid Readmissions Through Collaboration, or ARC, effort in California. Let's get started. Pat, the floor is yours.
Well, thank you so much, Raymond. I appreciate the opportunity to be here with all of you today and share some of the work that we've done in California for the past several years. As Raymond mentioned, we've been leading the ARC collaborative, which is Avoid Readmissions Through Collaboration, and this is a collaborative effort that is very generously funded by the Gordon and Betty Moore Foundation in Palo Alto. With Cynosure Health and the California Quality Collaborative, we staff the collaborative and work with the individual participating hospitals to help them in the goal to reduce readmissions. So I'm going to spend a little bit of time today just talking about how the collaborative is structured, some of the strategies that we're using, and the results that we've attained so far. So I want to start out by saying, kind of the obvious. If you go away from today's webinar and do what you did yesterday, your readmissions will not go down. So in order to reduce readmissions, we need to do things differently. So we have to be constantly looking at our data, our patients that are coming back in, seeing what is not working, to really continue to iterate on our own findings with our patient population to form new processes and to test new ideas to see a new path. Because if we do what we did before, our readmission rates will remain unchanged. And if our goal is to reduce, we have to do things differently. So when we started the ARC journey, we, of course, like all good collaborative, selected our aim, and we wanted to be, pretty out there and assertive, and we decided that we would have our goal be to reduce 30 and 90-day readmissions by 30% by the end of this year. So although this is a pretty aggressive aim, we knew of other organizations that were able to accomplish it, so we believe that we should have a bold aim for our efforts, and we kind of coined the 30-30-13 as an easy way to have all of the participants remember it, and we could have it be front and center in our work to be constantly reminding us of where we want to be. So in order to accomplish our goal, we decided, in terms of planning what we were going to do, there were several core strategies that we wanted to implement through the course of our work together. And the number one strategy is to build a collaborative community with a shared goal. So, as all of you who are working on this effort of readmissions realize that it's not a one-off kind of solution. It's not a one-person kind of solution. It really is a very intensive effort that takes into consideration the needs and workflows of many, many individuals throughout the organization. I'm getting a chat that we're losing audio. Can you hear me?
This is Raymond Carter. You're fine.
Okay. Maybe it's Kathy who's having problems on her end. All right. Well, anyway, so sorry. So we obviously have to work together, working across the continuum to see where we have gaps, where we need to fill in. Additionally, sharing evidence-based transitions of care models and implementation practices. So, we can go out into the literature and we can learn about BOOST and we can learn about Project Red and we can learn about care transitions and Mary Naylor and all of the rest. But in addition to learning about the models, we have to implement the models. And through the effort of the collaborative, we can share and do share, facility to facility, how they're implementing the model. And what I can certainly tell you is that people have chosen different models and organizations have implemented the same model differently, and we see successes across many different settings with their implementation. So we're constantly trying to glean the learnings and, again, share them back into the community so that there's generalized knowledge about this. Additionally, we have the opportunity, again, through the funding through the Moore Foundation, to offer on-site technical assistance. So I, as an improvement advisor, am able to go to the hospitals and visit with their teams and go to some of their meetings and help coach and support them in their work, which has been a really great opportunity. And we also, hold our participating organizations accountable by having them submit data. So all of the participants submit their 30 and 90-day readmissions on a monthly basis, and we are also collecting the HCAHPS scores, the care transitions scores, so questions 23, 24, and 25. And we watch those individually. So we're looking to see if the individual hospital is making progress over time, and of course in aggregate if we're making progress over time. All of the participants enter their data directly into a secured website that we've built, so they can see as soon as they enter their own data, how they're doing, how the collaborative is doing, but also importantly and somewhat of a motivator, they can see how they're doing compared to others. The data is blinded, so they don't know who the other hospitals are, but they can see their own hospital. It shows up in a different color. So that's been a good tool for the hospitals to be able to use. So of course we set out the plan, set out the strategies, and then had to engage people in the work. And I think it's been a growing kind of community of interest in readmissions work, and that is partially due to readmission penalties and more information about readmissions, and certainly the failures that we see coming back and in terms of our own core values as healthcare providers, knowing that we can do a better job. So in terms of really engaging people in this journey, I think the interest level has been there, so that has been a fairly easy thing to do. So we set aside a guide to help the organizations back in 2011, kind of a step-by-step, so a how-to guide, how to get going, how to form your team, what to do once you form your team, et cetera, to give the participating hospitals a roadmap, so to speak, of how they could work. And you can certainly go to the website and pull this down if you'd like. It's www.avoidreadmissions.com. One of the very important things in the guide is really an RCA tool, for lack of a better word, a diagnostic tool. And we strongly believe that the participating organizations need to look at their own readmission population and find out what's driving readmissions in their own organizations. So to do that, it's really a multi-pronged approach of assessment. And we wanted the organizations and help them to review their own data. So taking a year's worth of readmissions or 6 months or whatever you kind of could get your hands on, and really dicing and slicing that data to learn where are our patients coming back from. We have hospitals that found out that many of their readmission patients were coming back, had been sent home, had no home health, had no services with them. So that was an opportunity for those organizations to say, hey, can we do a better job referring these patients to home health? Can we provide some other services for them when they get home? Conversely, we had hospitals that said, hey, the majority of our readmissions are coming back from skilled nursing facilities, so we need to really work with our skilled nursing facilities to see what we can do there. So allowing the data to really drive the strategies for the individual organizations. Likewise, we had organizations look at the diagnoses, and to some there were ahas there. Most people think, oh, it's always going to be heart failure, it's going to be COPD, on and on. Whereas when organizations looked at their data, not everybody found that. We had some that found sepsis to be their #1 reason for readmission. We had some that found a low number but a very high percentage of readmissions of HIV patients. So again, this informs the hospital as to what strategies to implement, what ideas to test. And there's more work that can be done in terms of looking at your data, age, sex, zip code, all of those things can give you some useful information, again, about where you could target or help to start your improvement efforts. We also encouraged our participants to talk to their patients and learn from their own patients, from their perspective, why is it that you came back to the hospital? And I was very much taken back by a particular organization that did this, and they had a patient that had been readmitted 3 times and had 2 ED visits within a 6-month period of time. And when he was interviewed, why did he think he came back to the hospital? He said, "I ran out of Lasix." So, that just tells us, wow, if we can help that person get his medications, reliably, then, he could have a whole lot of interaction with the healthcare avoided. He could be much more self-sufficient. He would be, not necessarily having to go through that coming back to the hospital, wear and tear on himself and on his family. Additionally, we wanted our organizations to review the medical records of those same patients that they talked to. So, for those patients, what did their medical record look like 6 months back? Were they in and out of the hospital, in and out of the ED? What kind of support did they get when they were discharged? What kind of education did they get? Again, to learn what's going on. Also looking at talking to the providers. Did the doctors in the community know that these patients were even admitted to the hospital, were discharged, meds were changed? Was all this information communicated to the PCPs back in the community? And sometimes, we unfortunately found that the PCPs were not even aware that the patients had been admitted, let alone that things had changed. And then also importantly was reviewing internal processes. So asking, through a gap analysis, not only do you have, a policy and procedure that says you do something, but when you actually go out on the units, is there evidence that it's happening? Are the staff able to tell you about it? Can you see it in the practice that's happening every day? So in doing all of these things, we felt that the hospitals got a really good sense of what was going on for their own readmitted patient populations, and they were able to find the bright spots. So they were able to find, things that were working really well. And of course, if you find things that are working really well, you want to understand why they're working well and hopefully replicate them in other parts of your organization. Additionally, they found things that were broken or unreliable, and again, those are the areas that we would look at to prioritize for performance improvement. And after doing this entire kind of diagnostic assessment, then we asked the organizations to select a model. So again, there are evidence-based models. Many of you may be aware, as I mentioned earlier, Project Red, CTI, et cetera. And depending on what the organizations found from their own assessment, they selected a model or models that would best fill in the needs for the patients that they had and the issues that they found through their diagnostic journey. One thing that we really wanted to stress, and I have to say Eric Coleman kind of brought this to my attention and the attention of our group, is to get away from that notion of non-compliance and get away from that notion of, we did everything we were supposed to do. We gave them this, we told them that, and yet they still came back. And what Dr. Coleman certainly encouraged us to do, and I would encourage all of you to say, if we're tempted to say the patient is non-compliant, we need to further question ourselves and to further say, well, what are the reasons why that patient is non-compliant? Was the patient non-compliant with taking their medication because they got the symptoms from taking their medication that they couldn't figure out how to manage, they weren't able to get to the pharmacy, they didn't have enough money to pay the copay? All of these issues can impact the person's ability to take their medications as we would certainly like them to. So we really want to not rest on the non-compliant box there, and we really want to encourage everyone to dive a little deeper, dig down, and understand the factors that are preventing that patient and the caregiver from being successful with the plan that we tried to design for them. So of course, once we have a model in front of us, we need to, PDSA, whatever your performance improvement model is, but you want to, test some of those new ideas. So for example, if you are testing post-discharge phone calls, you would want to test a plan for that, who might do it, when, how, and then carry out your test, study, and then act upon your data. So you would want to determine how that evidence-based strategy would be able to be carried out in your organization, and you might have to try numerous iterations to see how things would best work in your organization for the implementation piece of it. All of the models are somewhat similar. They all contain some common elements, and one of the main elements that we've been focusing on are the connections across the continuum. So not only are we looking at internally what we're doing, say, within the hospital, but we have to look to see what's happening once that patient leaves the hospital. How are we transitioning their care to the other community providers? And importantly, how are we and or the community providers reinforcing that after hospital care plan so that the patient and their care providers can be helped and supported and have that reinforcement that they need in order to successfully carry out the plan. And importantly, we realize that we have to customize. So not one cookie cutter plan is going to work for all patients. We have to see what the particular circumstances are for the individual patient and their caregivers in order to really develop a successful plan. So throughout the course of our first effort in ARC, our initial ARC grant, we really focused in on all of these topics. We looked at some of the practices across the participating hospitals, as well as again, receiving information from the founders of many of these models and those across the country who are doing some great work in these topics, as well as many others. So important for purposes of a collaborative to be constantly, learning from others and seeing who's doing has a successful practice, to see if others can join in that practice, share in that practice, learn from that practice, take whatever they are learning and bring it back to their own organizations. Just the other day, we had a very focused meeting on medication reconciliation with our pharmacy group, and had several organizations share the strategies that they were using very specifically, very down into the nitty-gritty how-tos. Similarly, we've had sharing on collaboration with skilled nursing facilities, health literacy, all of these topics. And because of that educational forum, the ability to share information, the ability for people to come together, we gained a great deal of momentum and started our feeling that we were doing a job in ARC to provide support to folks working on this. And as a result of that, we felt that our journey couldn't stop at the end of our first grant. And as a result of the success that we were having with bringing people together and sharing information and having success with facilities being able to reduce their readmissions, we were awarded a second grant. So ARC 2 began in the fall of last year and will continue until the middle of next year. And we will continue the work of all of the first efforts of ARC in terms of bringing the participants together and sharing knowledge. But in ARC 2, we are definitely branching out more into the community to bring the community together around this effort of care transitions. And some specific strategies that we have included in our ARC 2 are to develop a patient advisory council for the collaborative. So we've asked our participating hospitals, we've gone to community settings, and we've talked about seeking patients who would come together and give us their feedback about transitions of care. And we have two patient advisory councils going right now. We have one who are direct patients of our facilities, and then we have another who are more I would consider professional caregivers and the like who have input as well. We've also decided in ARC 2 that there are certain groups that have special interest and would benefit from a more intense opportunity to share information. So as I mentioned, we had a forum for the pharmacists to come together to talk about some of the things that they're doing. One of the things that we saw, again, looking at our data and talking to our participating facilities, is that substance abuse was a big problem, a big barrier for some organizations. So we brought together a convening about substance abuse and some strategies that could be tried for assisting with addiction problems. We're just in the process now of developing a home health convening. We'll be bringing our home health agencies together as well as their hospital partners to talk about best practices there. Just anecdotally, we had a home health agency share at one of our last meetings that one of the struggles they had was getting a response from the physicians, and they developed what they called a red flag fax, and they would send this red flag fax to the physicians when, for example, they were seeing a heart failure patient that was starting to deteriorate, and because of this, visual red flag fax, they were able to get communication with the physicians more effectively. So that was just a really simple idea that many people got at the meeting, took away, and were able to implement in their own organizations very quickly. We're also looking into the future about business case, because as ARC 2 ends up, how will these efforts be sustained in the organizations going forward? We're also going to have a Project Red boot camp, because many of our organizations did select Project Red, so we're going to have a little deeper dive into that in November. Continuing our collaboration with our skilled nursing facilities, and we're also in the midst now of planning a Day of Transitions mapping exercise, which is we kind of got from the United Hospital Fund in New York, and we're going to be trying that in one of our counties up here. So one of the strategies that we feel is very simple but incredibly effective is getting people in the same room. So bringing people together from the community to just learn about what everyone has to offer, learn about what their frustrations are, and just start with one issue. We found this to be very effective in bringing our skilled nursing facilities together, and they're really working very well now in reviewing cases and developing some great synergies in their efforts. So with all of this effort, we've had some success that we're very proud of, and as of actually the end of last year, we had prevented over 3,000 readmissions from our participants, and that equates to about $32 million. So that's a big chunk of change, and as a result of that, we did receive some positive press. We were in the Wall Street Journal and some other publications as well. And we consider that great news, but we still have a long way to go. We haven't reached our 30% reduction goal yet. So we, again, are constantly asking us what's preventing us from attaining our goal and what do we need to do differently. And again, it's really reflecting upon those patients who are readmitted, getting into the weeds, finding out what the failures were, and trying to modify our programs accordingly. And through this, we know that one of the most important things is really just hanging in there, because this is certainly a marathon journey, and it's not, as I said, a one and done. So with that, I will say thank you, and appreciate you letting me to share a little bit about what we've been doing at ARC. And as Raymond mentioned, here's my contact information. If you have any comments or questions, feel free to contact me.
Wonderful. Thank you, Pat. For those of you on the line, if you've got questions for Pat, go into the chat window and type your question and hit send, and we'll pull it up while we're waiting for people to do that. Pat, obviously any collaborative, not everybody joins. So I'm curious, of the hospitals that were the first in and sort of the leadership group in the collaborative, do they have, common characteristics? Are they characterized? Is there a strong CEO? Is there a strong nursing staff? Is there a strong physician culture? Is there anything that sort of characterizes the people that volunteer to come into the collaborative?
That's a great question. I wouldn't say there's just one thing. I think what always happens is that you sometimes just hit the sweet spot. The organization is just at the point in time where it's a priority for them. They're ready to listen. They want the support, and it just, you just connect. And then, once that happens, you want to really move forward with that energy. And what we found, the way we set up ARC-1 was that, you could be a full participant or you could just be thinking about it. And what we wanted to do was get the people who were just thinking about it converted, and that's what we were able to do. So in ARC-2, we have, far more just full all-in participants, and we don't really have that kind of hanger-on model anymore. So that's that. And I do see a couple of questions in the chat box. Do you want me to go ahead and answer those?
Yeah, sure, go ahead.
Sure. So in terms of the business case, what the business case is about is really looking at your own organizational finances. So how much does it cost for you as an organization to implement some of these strategies? So for example, do you have a special discharge advocate, named person? Is that person a clinical person or a non-clinical person? What does that person cost? And then, what is the saving, so to speak, to your hospital from not having that person readmitted, perhaps having a person, say a person who comes in for a surgery, fill that bed instead. So it's really looking at all those factors from a more economic perspective. And then another question is, are there specific steps targeting SNF frequent flyers? In terms of the high utilizers, absolutely there are specific steps. So some of the organizations are really focusing on their high utilizers, so they are taking, again, a review of their data. They're looking at targeting individuals who are high utilizers and providing them additional services. So again, it could be much more comprehensive services than what we would have a kind of traditional, we'll call you up after your discharge type thing. So what many of the organizations are doing is they're doing a risk stratification of some sort going in, and then we might have 2 or 3 risk buckets, and the higher risk would be those who will be getting more intensive supports, and that could be social support, it could be Meals on Wheels, it could be all kinds of different things, clinical support as well. So absolutely, there are strategies for the very high utilizers also.
Hey, Pat, this is Raymond Carter again. Actually, my business case question was going to be a sort of variation of what Kim asked, which is that obviously when you are reducing rehospitalizations under a fee-for-service model, you're reducing your income, but under a shared savings model, you're generating potential shared savings. And I'm curious how many of or what proportion of the hospitals that are in ARC are in some kind of ACO or accountable care light or bundled payment or shared savings model, so that there's a much clearer ROI for them than there would be in a straight fee-for-service system.
Yeah, and actually the clear ROI is not there on readmissions, as you mentioned. At least right now, for most people, reducing readmissions means reducing admissions, which is not necessarily a good thing for the bottom line. But what I find, Raymond, is that the folks who are interested in this, know that this is the future, and they want to really get ahead of this. And they know, from a patient's perspective, it's obviously the best thing to do. So it doesn't always pencil out from a business perspective, but I do feel that there is a lot more interest from leaders because of the penalties and because of the connection and value-based purchasing to the HCAP scores that relate to care transitions. So I see that as more of an interest, even though it's not like an exact dollars and cents benefit. There's definitely interest there, because I don't think any hospital administrator wants to get a penalty or get a low score for purposes of how their organization is viewed by their community.
Sure. I don't see any new ones in the window. I have one more, and then maybe we'll move on to Dr. Asfar and save a little time at the end. Oh no, here's a question right here. Sorry. Go ahead and take.
Okay, so the question is, are the SNF targeted strategies detailed somewhere? I can email this person offline. There's definitely information about that on the website, Irving. So if you want to go to, again, www.avoidreadmissions.com, you'll see some of that SNF work. But if you have any specific questions, I'd be happy to discuss them with you offline.
And this is Raymond Carter again. This was my question here. There's some feeling that the increase in the hospital's use of observation beds rather than inpatient beds has to do with the fact that if a person in observation gets admitted within 30 days, they don't count as a readmission because they were not inpatient. And I don't know whether that's true or not, but I am curious whether in the data you're benchmarking, are you tracking observation versus inpatient decisions?
We are not tracking it as on whole as a collaborative, but many of the individual organizations in terms of their own measurement strategies are looking at various process measures, and they also are looking at ED visits and outpatient, just outpatient stays, observation units. From a collaborative perspective, our kind of point of view is that we don't think observation is the way to go. I mean, we don't want to say, okay, you didn't have a readmission, but you had an observation, so it's okay. We think if the patient came back, even if they have to come back for observation, that, again, it's an opportunity to do a better plan of care, the better opportunity to manage in the community. We're seeing having to return to the hospital, be it an ED visit, be it an observation visit, still as a failure in the overall scheme of things. So we really want to not encourage that as a strategy to reduce readmissions.